So good morning, everybody, and welcome back to the Journal Club session. I'm delighted today that we'll be joined by our colleagues from Bern University Hospital in Switzerland as we discuss the paper from Jack Intervention about impact of echocardiography on left atrial appendage closure. I'm pleased to welcome Roberto Galea, who will be presenting the paper, and a very warm welcome to Professor Lorenz Räber, who's joining us, who will be our expert discussant. So Roberto, if I can encourage you just to share your screen, and then we can get started.
Yes, sure. Thank you, Arif.
If anybody has any questions during the presentation, please type them in the chat and we'll address them at the end. And at the end, there will also be an opportunity for questions and answers. So looking forward to all of your participation. And
so I think you can see my screen, right?
yes, everything's good.
Perfect. Okay, so shall I start? Okay, thank you very much, Arif, for having us. It's a big pleasure for me to present this study that was conducted in the last few years by our team. And so I think we are all aware about the important role of left atrial appendage in thrombogenesis. And I think also that are quite clear which are the limitations related to oral anticoagulation. And against this background that left atrial appendage closure has become a standardized procedure over the last decade, with a significant improvement in terms of safety and technical success. The reason may be several, as the introduction of new devices, introduction of new material, and a more accurate procedure planning and guidance. And in this respect, the latest European expert consensus document has dedicated a sizable section to this topic, underlying how important it is to perform imaging before, during, and after the procedure. Today, we are going to focus on procedural imaging, and that is very important to exclude LAAC thrombus in order to size the LAC device, to guide the transeptal puncture, to guide the device deployment, and to assess the device implantation right before and right after the device release. To do that, we have three strategies. So the first one, fluoroscopy plus transesophageal echocardiography. That has become a standard, the standard of care in clinical practice, since this strategy was used in the context of a vast majority of randomized and observational study, on which the safety and efficacy of left atrial appendage closure has been proved. Then the second strategy, fluoroscopy plus intracardiac echocardiography. And I think we must be proud that was an Italian study three years ago to prove in a multi-center cohort of consecutive clinically indicated LAAC procedure that TEE guidance has compared to intracardiac echocardiography guidance achieve a similar rate of procedural complications. As a consequence, fluoroscopy plus intracardiac echocardiography has become a valid alternative to transesophageal echocardiography guidance. Third option, fluoroscopy only guided procedure. And in these strategies, according to the latest expert consensus document, should be performed only in few experienced centers. And please take a look at these images that give to you the idea about which level of expertise is required to guide the transeptal puncture, to size the LAC device, to guide the device deployment, only being guided by fluoroscopy images. However, it's important to underline which are the advantages of these strategies, as in terms of anesthesia, that in this procedure is typically local, in terms of intervention duration, costs, and in terms of TE-related complication, especially upper gastrointestinal bleeding. And probably these advantages pushed some centers, especially outside from Europe and US, to continue performing left atrial appendage closure only, fluoroscopy only guided routinely in clinical practice. Here you go, the two only studies performed in Indonesia and China respectively that tried to compare the fluoroscopy only guided procedure with T-guided procedure. And as you can appreciate from this box, although a numerically higher rate of procedural complication were observed in fluoroscopy only guided procedure, no significant difference was detected in terms of safety between the two groups. So the lack of evidence about the clinical benefit of echo guidance pushed our centers to design this study. So we therefore decide to compare fluoroscopy only guided left atrial appendage closure. Majority of them were performed between 2009 and 2015 with some operator who decide to continue performing routinely these procedures with the echocardiography guided procedure. Majority of them were performed between 2015 and 2020. From this monocentric cohort of consecutive clinical indicated procedure, we exclude patients who did not sign the consent, patients who were enrolled in randomized clinical trials, and the few only fluoroscopy guided procedure that were preceded by a CT scan. We pre-specified three combined endpoints. Safety endpoint, that was the composite of the typical major complication related to left atrial appendage closure observed within 7 days after procedure and that were adjudicated by the clinical events committee as device or procedure related. Second combined endpoint, short-term technical success, defined as adequate LAA exclusion as evaluated by LA angiography right after the device release, in absence of peri-procedural device complication. And you can read the list of these complications in the right side of the slide. Long-term technical success, defined as adequate LAA exclusion as evaluated by TE at the follow-up, in absence of device-related complication at follow-up. So the two procedures different for some step. The LA thrombus was excluded before procedure in the FG group by means of a pre-procedural TE, whereas in the EG, in the vast majority of EG procedure, by means of a peri-procedural TE. Then the anesthesia was local in the FG group, and the general or conscious sedation was used in the echocardiography guided procedure. Then the four typical steps of left atrial appendage closure, interatrial septal puncture, device sizing, device deployment, device implantation assessment were performed by means of fluoroscopy only guidance or echocardiographic and fluoroscopy guidance. The post-procedural management was pretty similar between the two groups, with a post-implantation drug regimen left to the discretion of the operator, the transthoracic echocardiography performed before discharge, and the TEE follow-up performed at 3-6 months. So let's take a look at the numbers. 811 patients were enrolled, were included in this analysis, 549 in the FG group, 262 in the EG group. Baseline characteristics. So the patients included in the EG group were basically older, with a higher bleeding risk and with a higher percentage of diabetes mellitus. Then the FG group was composed by a higher percentage of patients with a history of coronary heart disease. Baseline characteristic, presence of LA thrombus, chicken wing shape, sinus rhythm during procedure were more frequently observed in the FG group. The type of device implanted significantly differ between the two groups, with Watchman 2.5 and Watchman Flex implanted only in the EG group, echocardiographic guided procedures. Then the operators significantly differ between the two groups and also their expertise. Concomitant intervention were significantly more frequently performed in the FG group. So take a look at this number. Safety endpoint 3.4 in the EG group, 9.1 in the FG group. A difference statistically significant that was driven basically from a numerically higher rate of each component of the combined endpoint. And please see, take in account that no death, no TIA, no need for cardiopulmonary resuscitation or urgent surgical bailout were observed in the EG group. At the multivariable analysis, the echo guidance was the only independent predictor of safety endpoint, with the fluoroscopy only guidance associated to a threefold higher risk of major complication. Then short-term technical success trended higher in the echo guidance group, with this difference was driven by a significantly higher rate of device-related complication at 7 days. But please see that early device embolization, all the 11 cases occurred in the fluoroscopy guidance group. However, the short-term the echo guidance did not show to be an independent predictor of short-term technical success. On the other hand, long-term technical success was significantly higher in the EG group, and again, this difference was driven by a higher rate of device-related complication at the follow-up in the FG group, and at the multivariable analysis, the echo guidance was an independent predictor, as well as the male gender, of long-term technical success, with the echo guidance associated to a 4-fold higher rate of long-term technical success. So our study has some limitation, of course. The non-randomized and observational design, partially retrospective, and so the associated potential unmeasured confounders. Then the measured confounders has concomitant procedure, the LAAC device, the kind of anesthesia, all variables that were included in our multivariable analysis, and then the sizable proportion of patients who did not perform LA angiography right after the device release and the TEE follow-up. So, in conclusion, left atrial appendage closure is a valid therapeutic option for patients with non-valvular atrial fibrillation and contraindication to oral anticoagulation. The imaging has to be performed before, during, and after the procedure. And in particular, the echocardiographic guidance is recommended in order to reduce procedural complication and improve long-term efficacy. Now we have some evidence about that. And let me conclude with a personal consideration. I'm very curious to see next European expert consensus document, and if the expert will review the indication to fluoroscopy only guided procedure. And thank you very much for the kind attention.
Great. Thank you very much, Roberto. A very nice presentation and summarizing the topic. I'd like to invite Professor Lorenz Räber, if you could kindly come in and share with us a little bit about, let's say, your journey with left atrial appendage, starting from fluoroscopy and now moving on towards echocardiography. For us young interventional fellows, what are the key things that you've picked up during this, let's say, shift in procedural approach over time?
Yeah, thank you so much. Thank you, Roberto. This is obviously a nice example of conducting registry-based, or let's say observational research, and I would highly appreciate to make a comment on this first, because to me, now having fellows that are interested in research, I guess, online, my first comment is focusing on how to identify clinical research. As you nicely alluded to, there is a consensus statement, but usually consensus statements are made by experts and they are not necessarily based on data. As you nicely showed, Roberto, the existing evidence on this very topic, which is an important one in daily practice, is based on a handful of patients. Nevertheless, the European Association of Rhythmology and the LAA consensus document states that the angio-guided is a potential option. The angio-guided is a potential option. However, if we then go to the references, we will detect or see that there is not sufficient data available, and this should trigger then our initiative, because this is a good field of research, and then subsequently, because it's the logical step to acquire more data in this field, will be accepted in respectable journals, of course, if you're lucky. That's my first point. Second point, it is clear that there will not be an RCT in this very field, because there is a common consensus that probably echo guidance is superior. And this is a good reason to perform observational research. So in every field where there is absence of RCT data, and even more so if you suspect that there will never be RCT data acquired, it makes very much sense to go for observational research. However, we need to be careful. If we look through the baseline characteristics, as you did, Roberto, we note that there are substantial differences, and we have to discuss those and take into account. First of all, we have to state that the echo guidance group was significantly sicker. That speaks for our hypothesis that TEE guidance is more safe and more efficient, of course. So if anything, the echo guidance group was at higher risk for mortality, but instead death and other endpoints were less frequent. I mean, the age was higher, the bleeding risk was higher, much more diabetic patients, more history of bleeding, etc. That's pretty clear. Second point, there are important differences in procedural characteristics, and we need to take those into account. First point I would like to raise is there is a huge difference in terms of amulet versus Watchman devices used. The Watchman is not a device that you can use by angio guidance. There are no established criteria to implant a Watchman based on angio guidance. However, there are clear-cut criteria for angio guided implantation with the amulet. Accordingly, only amulet was used for angio guidance. Why is this important? If we consider the very recently published Amulet IDE, which led to the FDA approval of the Amulet device, published 3 or 4 weeks ago in Circulation, we note that the Amulet leads to a higher frequency of pericardial effusion and tamponade. Now, this needs to be carefully taken into account when we look at the outcome data, because safety endpoint was driven also by a higher risk for pericardial effusion in the fluoroscopic guidance group. Well, it tended at least, so it contributed to the endpoint. So is this the reason? Probably not, because other important endpoints like stroke or death or bark bleeding were also in favor of the echo guidance. So the difference in device will probably not explain the result of this analysis. Second important point, there is a substantial difference in concomitant procedures. If you may go back. concomitant procedures like PCI and PFO closure were significantly more likely to be performed in the angio-guided group. Is this now explaining the results? Can you go back to the procedural complications? Yes. So is this now explaining the safety results? Is it just a function of the more frequently performed concomitant procedure? That's the question. What would be your answer? If we look at resuscitation, and it's highly unlikely that PCI or PFO closure triggers resuscitation. For those who perform LAA procedure, resuscitation is usually occurring if you have a large air embolism, which leads to transient ST elevation in the inferior region due to air embolism into the right coronary artery, because the right coronary artery, of course, is the place where the air will go, and due to cerebral air embolism first. And the second point, the need for surgical payout, of course, is a function of device embolization. So with that, mechanistically, we can confirm that it is not related to the substantial difference in concomitant interventions. Now, let me get back to a broader view after having scrutinized a bit the observational design. As Roberto said, there are three potential methods how we can perform LAA occlusion: angio, transesophageal echocardiography, or intracoronary echocardiography. What are the pros and cons? Nowadays, I think there is a certain indication, a very small window of indication for angio-guided. This would be the patients that have a contraindication for a TOE probe, as for example, a patient with esophagus varices that are a clear-cut contraindication. Now, the argument then would be, well, then why don't you perform intracardiac echocardiography guidance? That's true, but it's only true, and that's an important point, if you have a high degree of experience. To conduct intracardiac echocardiography during the procedure means that you have to fulfill a challenging task for which you need substantial experience. So in a scenario where you are at a hospital with TOE guidance and you usually don't do IC guidance, to do ICE guidance in selected cases is not a good idea, because the fact that you don't have experience with ICE guidance will lead to complications. Why? Because the probe needs to be entered in another large bore, with another large bore access, 8 to 9 French, and you need to direct the probe into the left atrium, which of course can also lead to embolization, to air embolism, etc. So this is the reason why still there is a small window for angio guidance. However, it makes absolutely, in routine, it makes no sense as shown by the data. And the underlying reason is the LAA anatomy is highly complex in some cases, not in all, but in some cases. And with this, you need to be able to define, first of all, the size of your device, and second of all, the landing zone. These are two critical issues. If you choose the wrong size, or if you choose the wrong landing zone, what will be the consequence? The consequence is that you have to do a recapture, try again, recapture, try again. And this repetitive recapture and try again means that it will ultimately lead to complications such as air embolism or pericardial tamponade, because of course, by doing so, you irritate the left atrium. And this is the reason why you should only perform LAA once you're fully informed about device size and landing zone. And this, by the way, just a comment in brackets, requires also a very good understanding and communication with the echocardiographer. The echocardiographer nowadays, and this is not only true, of course, for LAA, but also for MitraClip, TriClip, etc., is highly relevant. So if you don't have an experienced echocardiographer for interventional procedure, of course, that will lead ultimately to a higher degree of complications. And my last comments is what you always should, and I guess in 21, even more so than 10 years ago, you have to always ask you, are the significant, I mean, significance is one thing, no? But is the significant result meaningful? That's the key question. Is it meaningful? If you have a 30,000 patient RCT with a number needed of treat of 200, that's not meaningful. But apply to this study, the question is, is it meaningful? And I guess, yes, of course, if people have more resuscitation, more surgical bailout for a prophylactic procedure, it is highly meaningful. And yes, of course, if you achieve a complete sealing of the LAA less frequently with angio guidance, of course, it is meaningful. And with that, I think I would conclude my first round of comments, and I'm happy to stimulate the discussion. Maybe there are questions.
Great. Thank you so much for that overview. So I'd like to invite the audience. If anybody has any questions, please turn on the microphone and we can take the questions now if anybody has anything.
Good morning. Good morning, everybody. I'm Giulia Masiera. I want to ask to Professor Räber, in case of inconsistency between the sizing between the eco-guided and the fluoro-guided, how do you manage this different indication to sizing of a device?
Yeah, that's a very important observation and question. So basically, what we routinely do is we take into account all the three measurements by CCTA. We routinely do CCTA up front and no TOE just for a patient convenience reason. And then we assess TOE and angio measurements. And at the beginning of this process, you will be confronted quite frequently with inconsistent measurements. And the main reason is that you don't measure at the same position. So I think the first step is that you agree with the echocardiographer and with the operator and the one who does the CT measurement, well, usually the operator, where exactly you measure and where finally the device will be implanted, because that's not always the echocardiographer has not always the same understanding as the operator where the device at the end should be placed. So this can be the most important reason for inconsistency. Generally, the TOE measurements are a little bit at the lower side, and what we do is we do routine, and we observe this as well as you indicated. And what we nowadays do is we refer to the 3D measurement by TOE. So we do a 3D measurement and take the maximal and the mean diameter, and this is actually quite well corresponding to the CT measurements. But at the end, it always has to be a discussion within the team to learn from the imaging findings and eventually to improve in the future your assessments.
Thank you. So we have about just 2 minutes left, let's say. So any other questions from the audience?
So good morning to everyone, and thank you to present your paper. Congratulations, firstly. Then I would ask, I noted that in both groups there was a final angiographic check, if I'm right, in 80% of the cases. Do you still do angiographic control even in ECO-T guidance procedure, and just to check the leak or something, or you can trust only in echo?
You can trust in the echo. It's not needed. It's just for the, of course, in our genes, we have the fluoroscopy, you know, and you have, and you follow this genetic predisposition until the end of the life, probably. But let's take an example of a patient with renal failure. We do not inject any contrast. So we do zero contrast LAA occlusions in patients with a GFR below 30. This is possible and feasible. And what you should stick to is really the echo. Of course, the precondition for that is you have an echocardiographer that you know well and in whom you can fully trust, and with whom you have a large common experience. If you start, let's say, at a new institution or you welcome a new echocardiographer, I would insist on the angiography for quite some time, at least for 50 cases, let's say, because I want to be sure that what he's telling me is true. No, and so as a conclusion, you don't need it if you have a high quality echo imaging. Then you don't need it.
Great. So I think we've just come on to time, so we'll just wrap things up there. So it leaves me just to say a very, very big thank you to the team from Bern. So Roberto Galea and Professor Lorenz Räber, it's a real pleasure that you joined us today for this discussion, to share your paper and also some very nice insights into, I would say, how to read such a paper and look more closely and analyze some of the data. Very educational and instructive for us fellows. So a big thank you. I hope you will join us again. We run this session every Friday morning, same time, different topics. So you're all invited to join us again and to spread to all of your fellows around Bern and wider. So big thank you, everybody. Have a good day at work, good weekend, and see you again next Friday.